What a wonderful morning we've had. I thank you all for just excellent presentations and for your expertise. I know we're a little behind and we're going to get caught up, but as they take their seats, if there are questions from the audience, I'd appreciate your coming to the mic now. You can come to the mic. And if there are questions in the chat, I know that we'll get some assistance with those. Yes, sir, please.
Hi, good morning, everyone. My name is Jeff Lasso. I'm from Trinidad. I'm a public health lecturer here, actually. Okay, hearing me clearly?
Yes.
Yeah. Just a couple of quick questions to Dr. Easterling, and I believe Ms. McDonald might be relevant. As an advocate for healthcare models in the Caribbean, I think the universal healthcare model seems to be more appropriate. I'm looking at the US model, and I guess it's a more market-driven, insurance-based model. And I am seeing greater and greater inequities. So I'm looking at the sustainability of the model, and I was wondering, what are your thoughts on which model should I be an advocate for? The second question is to Dr. Beverly. I'm very concerned about the dismissive, often very time-restricted sort of interaction of patient-doctor consultation. And it seems to be maybe not efficient or triggers sometimes resistance from some people. I know people that I'm familiar with that kind of resist going to the doctor because they feel very dismissed. And the third point is something that I was very intrigued about with Ms. Turner, I believe. When you indicated about, I think, certain religions may not allow for certain types of procedures, for example, blood transfusion with the Jehovah's Witness and with vaccinations. But I'm curious as to minors and dependents. I know I'm from a British Commonwealth jurisdiction, so the legal system may be different, but how do you resolve parents or persons who are in charge of minors making a life-threatening decision for these type of medical interventions?
Thank
I
you.
hope it was clear in my
Yes, thank you very much. And so the first question, Dr. Easterlin, if you'd like to address that, and then Ms. McDonald.
Okay, mic check. Thank you so much for your question. Unfortunately, I'm not going to have a satisfactory answer because I think part of it is going to have to you're going to have to do some homework on your own and sort of figure out what's happening on the ground, right? And so it's hard for me to say which of the two models, if even those two models are the most appropriate. And so, part of my remarks was sort of thinking about what does it look like for us to foster that meaningful engagement, to really think about how you pose that question to the folks who are living through the experiences that you're trying to change and trying to transform. How can they be the answers to the questions that you have? And I think that's the process that we really have to get better at doing. We're not going to come up with the answers. I think we're going to help come up with some of the theories and sort of postulate about what the approach may look like. But that's only part of the solution. And so I would say that we're still trying to figure out what that process looks like. I think that we have come up with some of those levers. We're sort of looking at what those factors are. But at the heart of it is really making sure that the voices of those who are most marginalized and often are out of the conversations and not in the rooms to really drive change, how do you really center their voices and make sure that they are going to receive the benefit of what you're aiming to do? So again, not satisfactory, but it's really about that process. So
Thank you very much. Ms. McDonald.
Say briefly, and I completely concur with what's already been said. And I'll just say briefly, when you ask which system should you be advocating for, for me, it's really about understanding what's doable in the context of which you're trying to achieve it, right? And so we saw this debate happen in the U.S. in terms of the Affordable Care Act, and we saw the amount of pushback, and we saw what we ended up with was a compromise based on what was doable at the time. And so I think, we have to look at that in the context. The right thing to do, I think, is what I'll go back to my mantra, right? What advances the needle? And I think that is so situationally specific that there's no blanket, you should advocate for this and not for that.
Thank you very much for your response. And Dr. Beverly, the time constraint comment. His question was regarding the time constraint that we have in seeing our patients.
I think, I think I'm have a different approach based on my experience with the readmission prevention and the readmission results from Kings County from 30% to 18.7 within 2 years. It's not like the population changed. And I think when people talk about social determinants of health, is it important? Yes. But it doesn't mean because I live in the projects, my blood pressure can't be controlled. But it gives hospitals a pass, as far as I'm concerned. And I trained at Harlem Hospital back in the day. So if social determinants of health was a problem, okay, but we were expected to deliver excellent health care, whether you were a drug addict or whether you were a churchgoer. And I think when it thinks about time, I think if we engage the patient in a more humane process, the time over the course shortens. It shortens, and people are less stressed out. But if you continue to think I'm a problem and there's a discussion back and forth, then, well, I don't have enough time to do this, and I don't have enough time. When we didn't take a lot of time with the patients that required an enormous amount of time, we just asked simple question, tell me what's important to you. Why didn't you do something? And we were able to solve those problems. Did it solve every problem? No. But I think what's important to you and what we do in medicine, and we take a lot of time telling patient, well, this should be important to you. So I don't know why you're not following direction. How is that not important to you? Before you do that, why don't you ask me what's important to me? And then now we have a different conversation that it resulted in less time and more results, And just a point I wanted to make about East Trinidadian, I'm Ja, okay? Jamaican background. And what I found interesting, I just want to give this, there's a Haitian patient that was refusing, the language line. And, to be able to translate, she refused. And everybody said, well, what do you want us to do? She refused in the language line, how we're going to communicate. I said, well, why don't you ask her, if she doesn't want to do that, why don't you ask her who she trusted to translate for her? And one of the Haitian nurses on the team said, Dr. B, it's because of the Papa Doc syndrome. And I said, what? Mm-hmm. She did not trust the language line because she didn't trust anybody. And so the policies that we have in place, I said, well, find out who she trusts, and her daughter. And they said, well, you can't do that. I said, what do you mean I can't do that? I can't do that, so we're going to have her sit in the bed and don't talk to her because she doesn't want the language line. And these are things that takes unnecessary long time. Give her who she trusts. And we got her daughter, and he said, well, we're going to have to report this to patient safety or whatever. And off the record, I said, you go report to anybody you want, okay, but I'm not going to have this patient sit in the bed and not be cared for because she doesn't trust the language line. And I say that to say the time that it took for all this didn't have to be, oh, you don't trust the language? Who's the best person to translate for you? Bring her daughter in.
Thank you, Dr. Beverly. And Ms. Turner, your question about the vaccinations in minors.
Yes, excuse me. The issue with minors is layered. You have a family or parent, a guardian who is the decision maker. Ideally, that decision maker should be acting with that minor's best interest. If the providers do not feel that is the case, generally the first line of approach would be to go to the hospital ethics committee to try to resolve the matter at that level. And if not, then the court is the ultimate arbiter of that decision. And courts can order that treatment be given against a parent's consent, against a parent's wish. So that would be how that would be ultimately resolved. But the hospital would have to initiate that process, since it's the hospital or the provider that wishes for that care to be given, and the parents are the ones that are refusing.
Thank you very much. Is there a question in the chat? Okay, we'll take one last question. Dr. Zinge, Howard University. Happy to see you here, sir.
Thank you, Dr. Pinkett. Thank you all for your presentation. Dr. Easterlin, I was in a conference, a Howard Retreat conference about, I think last month, with the new connotation on DEI. When I was coming here and I said, we're going to be fighting health disparities and health inequities, what is the relationship between these words? I mean, if the federal government says no more DEIs, but we need to fight health disparities because they exist, and health inequities, what is your take on, if a grant is not needed, we can use the word? Because in that other place, they said the students, medical students who are publishing are trying to avoid using those words, but they exist. Can we stop using the words because what's the relationship between DEI, health disparities, and health inequities? If you're not going to be funded by the federal government, we need to fight what we need to fight.
Thank you.
Yeah, no, thank you for that question. I think it is something that we're always going to have to be addressing and having more discussion and dialogue about. I think the fight is not about the word, right? And I think you alluded to that point. The fight is really on how we ensure that the resources that are available, that could be either through the federal government or through some other means, are being leveraged for the work that we need to do, right, in our institutions. And so I think it's going to really be important that it's up to the organization to really think about how they're going to double down on this work. And being clear about that we do need to figure out how we're going to double down on the approach while also still leveraging those resources. And so there are certain centers that are going to make decisions certainly about how they're going to change some of the language and moving away from equity or inclusivity or diversity, but to ensure that those dollars are still being leveraged to do the work that it was doing, even when you were using words. And I think that approach makes sense in this moment, because we're gonna get past this moment, right? We saw that where there was sort of a proliferation of resources following the murder of George Floyd in 2020. We saw there were resolutions, there were fundings, there were centers that were named. And now we're sort of, going through this this bust cycle, similar to how public health, there's a boom and bust cycle for DEI work as well. We're gonna have to figure out how we sort of navigate this moment, and that's also sort of figuring out how we collectively work together. There are philanthropic organizations who are thinking about how they continue to fund these efforts. I know Robert Wood Johnson Foundation is using their Equity for Action grant cycle to also fund some of the research that folks were doing using federal dollars, whether it was the National Institute of Health, to make sure that that work continues. So I think that's ultimately what you're trying to get at, is like, what do we do at this moment? And it's essentially, and I was just telling my daughter this, figure out how we continue to move forward, right? In this moment, that's what we collectively have to do. That's our charge.
Thank you very much. Ms. Turner or Ms. McDonald, did you want to comment on that at all, or? Okay, that's fine. Excellent job. Thank you so much, everyone. We appreciate your questions and the commentary. Oh, I'm sorry. I didn't see you there, sir. I apologize. We'll take this last question, and then we'll take a 5-minute break.
Yes, good morning.
Good morning.
Yeah, my name is Dr. Michelle Jose Charles. So I think I have the opportunity to come and really talk here because I'm a health first provider. I'm a member of Medinova. I'm a friend of Howard University, and I'm Downstate alumni. Trained here. And I trained here doing everything internal medicine and GI. So I'm a specialist. So the thing is, I didn't want to stay and not to come to congratulate you guys. You did an excellent job this morning. It's a nice, wonderful kickoff, because every time I go to a conference or I have an opportunity to listen to those topics, it's really, really helped me. And until now, that still really helped me in my practice. With 40 years of practice in medicine, especially here, in Brooklyn, capital of the world. So you have the opportunity to meet almost all those cases. So that's why I had to say thank you, guys. So you did an excellent job today.
Thank you so much for your comment. Thank you. We'll take a 5-minute break.